What's up, Ninja Nerds? In this video today, we're going to be talking about biliary tract diseases. There's a bunch of things to discuss within this. And again, remember, this is a part of our clinical medicine section. If you guys like this video, it really does help you. You can make sense of it now. Please support us. And there's many different ways that you can do that, but a couple of them are hit the like button, comment down in the comment section, and subscribe. It really helps out a lot. Also, for you guys' benefit, I really suggest go down in the description box below. There's a link to our website. We got a lot of cool premium things that I suggest you guys become a member and indulge in. It's like what? Like notes, some really good ones. Illustrations, I think, are really top notch. We're developing quiz questions. We're developing exam prep courses, and there's a lot more to offer there. So go check that out. All right, let's talk a little bit about this biliary tract diseases. So biliary tracts, just the basic anatomy of it is that you'll have your common bile duct here, right? So we have here, well, we're going to abbreviate this, the common bile duct, right? And then here we'll have the gallbladder. Here we'll have what's called the cystic duct. And then here you have what's called the common hepatic duct. This would be your gallbladder, and these are going to be some of those smaller hepatic ducts, like your right and left hepatic duct, which are break into smaller canaliculi. When a patient has a disease of these biliary tract system, what happens is it's usually due to one primary cause, by far the most common cause. And that's these dang stones, man, these little gallstones, if you will, that kind of can get shot out of the gallbladder, and it can get stuck in the cystic duct, it can get stuck in the common bile duct. Those are the two most common areas that these stones can really get lodged in and can wreak havoc on the biliary system. So the question is, cholelithiasis, it's really a term for these things called gallstones. It's that AKA gallstones, homie. That's really what it is. It's these little stones that are stuck within the actual, particularly in the gallbladder. And then what happens is if it's small enough, it can fling it out, maybe get stuck in the common bile duct, or it gets stuck in the cystic duct. And we'll talk about what those diseases are in a second. Thing I want you to understand is when a patient comes in with a biliary tract disease, yes, by far the most common complaint and classic finding is right upper quadrant abdominal pain and maybe some jaundice, potentially. But right upper quadrant abdominal pain is the big one to think about for biliary tract diseases. But let's understand real quick, how does cholelithiasis actually form? What are these like stones made up of? There's three types of stones. So by far, when we talk about these, it's going to be cholesterol stones, man. They make up pretty much most of them. They're like 80% of your stones, and then it's pretty much downhill here from here, 10%, maybe 10% here. Not too much for these, so we won't go too crazy remembering these, but do think about them if they come up on the actual exam. But cholesterol stone is by far going to be one of the most common types of gallstones. So you have to think, what are the causes? We don't have like specific causes. We have risk factors that people may exhibit in the clinical vignette that suggest, oh, this is their likely cause of their cholesterol-related gallstones. So we use a mnemonic, and I'm not trying to be mean. This is literally how it's commonly, remembered, is that these patients are usually female, fat 40, they're fertile, fair-skinned, and they have a family history of some type of biliary tract disease. Now, all of these things, what they do is, in some way, shape, or form, is they increase the amount of cholesterol that's present within bile, right? And you know that bile is made up of cholesterol, it's made up of bile salts, it's made up of phospholipids. If you increase the amount of cholesterol within the actual bile, it'll cause it to supersaturate and make these nasty stones. And so that's one of the reasons we get these stones, is that there's way too much cholesterol within the bile, and it stimulates stone formation, right? So there's one way. Cholesterol stones, female, fat, 40, fertile, fair-skinned, family history, and again, if I miss one, they're 40. So again, that's gonna be the big thing there to remember for the particular risk factors associated with cholesterol stones. The other one is these black pigmented stones. Black pigmented stones is usually primarily seen in a disease called hemolysis. So hemolysis is whenever you're popping open these red blood cells. Red blood cells, they contain a molecule called bilirubin. And bilirubin, especially the unconjugated form of bilirubin, we'll put like unconjugated. This is actually going to spill out of these red blood cells. Now the problem is is when you have a ton of this unconjugated bilirubin, when it gets incorporated into the bile, it causes the bile to, again, become more of a supersaturated solution and increases the risk of these stones forming, but they're really pigmented. And so that's why you get these black pigmented stones. But the same concept exists. If there's too much of this bilirubin that gets released because of hemolysis, then you'll end up with stone formation. And these are going to be very specific type of pigmented stones that'll arise here. And then the last one is brown stones. These are infected pigmented stones. I just kind of gave away the answer. You'll see this in patients where they have infections. And if they have an infection, very specifically, like you can see this a lot, and what happens is when you have tons and tons of bacteria, when you have infections, you increase the amount of bacteria that's present. And what happens is, if I increase the amount of bacteria that may be in some way connected to the biliary tree, these bacteria release a lot of these bacterial enzymes. And so then there'll be the increased production of these little guys here, which are called these bacterial proteolytic enzymes. Now these bacterial enzymes, what they do is they chew up some of the bile and make specific molecules that really help to increase the supersaturation and precipitation and form these nasty stones that we can see. All right, and that's the same concept, is that you're going to get stones out of these bad boys. So either way, what are we able to surmise from all of this? Regardless, when a patient has biliary tract disease, it often starts with cholelithiasis, gallstones, stones that form within the gallbladder. They can flick out into the cystic duct, common bile duct. What are they made up of? Depends upon the type. Oftentimes it's this one. Remember the 6 F's. If you can't remember that one, you think about the actual black ones, think about hemolysis. If you think about the brown ones, think about infected stones. Now, when a patient has gallstones, you can have them and sometimes be completely asymptomatic, never even know that you have them. But every now and then, a patient may experience this thing called biliary colic. Super common with cholelithiasis. Imagine one of these stones just so happens to ball valve back and forth. So it's here free, gets stuck in the cystic duct, flips back into the actual lumen, flips back into the cystic duct, flips back into the lumen. The reason why this would happen is usually a patient has a fatty meal. So they have some type of really, really fatty meal. And what happens is that increases the production of a hormone. It's called cholecystokinin. Cholecystokinin causes gallbladder contraction. And if the gallbladder contracts down and pushes one of those stones into the cystic duct or clamps down on it, that's going to precipitate a lot of pain. And so oftentimes this will really precipitate a terrible pain. And so fatty meals increase cholecystokinin, increase gallbladder contractions, and increase this pain that's usually in some ways intermittent, okay? It's because this thing isn't completely stuck, it's just ball valving in and out. Now, with that being said, when a patient has cholelithiasis, they may present with biliary colic or be completely asymptomatic. But what happens if this stone gets flicked out and gets stuck in the cystic duct, or it goes out here and gets stuck in the common bile duct and it doesn't move, it doesn't flip back to where it was originally? What's the problem? Let's come down and talk about that. So now we got one of these stones and it got out there and it's about to wreak havoc. So if the stone gets stuck in the cystic duct, so here's our stone and it gets stuck in the cystic duct, doesn't matter, cholesterol, black stone, or if it's some type of brown stone, doesn't matter. It got stuck here in the cystic duct. If it gets stuck in the cystic duct, what's the underlying problem here? Well, it's pretty straightforward. You're not able to move bile and other substances out. And so this is going to cause this back pressure to rise here. Now, as this occurs, what are you going to see? You're going to see a massive increase in back pressure. And that back pressure is going to cause gallbladder distension. And when that puppy gets nice and big and swollen, you palpate that thing, these patients are going to scream. So that's going to be one big thing. So increased back pressure. I done skipped a step here. Back pressure causes an increase in the distension. So this puppy gonna be swollen. All right, that's one thing. The other thing is that you're gonna have bacteria there. This is just a part of your flora, man. It's a part of your GI flora in general. So there's gonna be bacteria here. You can't avoid that. But if I can't move it along, because you know, where does the biliary duct eventually dump into? It combines with the pancreatic duct, it puts it into the actual, the small intestine. So it can be moved along. If it stays in one place, it'll cause infection. And so the other problem here that can arise potentially is not only increased back pressure, but you can have increased bacterial colonization. So now I can have an increased amount of bacteria that are colonizing. And then these puppies can cause inflammation and infection. And then you got a recipe with the combination of these things, dude, whew, you're gonna end up with a nasty, nasty problem such as cholecystitis. Now, this thing will start to become inflamed, so it's gonna be nice and red hot. It's gonna be distended, and it's gonna cause so much pain localized to that particular area. The other thing is that it's gonna become infected. This actual gallbladder become infected. And so we'll talk about some of the complications that can arise with that. Oftentimes these patients classically have right upper quadrant pain, and they oftentimes have a elevated white blood cell count sometimes. But one of the other big things is that not only do they have right upper quadrant abdominal pain, when you go and you take and you do what's called a press down on the actual right upper quadrant, and you have them take a deep breath in, they're like, they can't finish their deep breath because it hurts so bad. And it's called a Murphy sign. So right upper quadrant abdominal pain with a positive Murphy sign is usually classic of patient developing cholecystitis. All right, so cystic duct, cholelithiasis gets, boom, lodged there, can't go any further. What if it goes further and it gets lodged here? What's this one? This is the CBD, the common bile duct. Now, if it gets lodged here in the common bile duct, again, same thing is gonna happen here. You're gonna cause a back pressure. This thing's gonna get kind of distended, all of this proximal to the actual obstruction. Now, here's the thing, two things will happen. You'll get some of this distension, if you will, of the actual biliary duct. But here's the more important thing that's really helpful. Oftentimes, there's molecules that are present in the bile that are very specific and help us to identify that under lab values. And so one of the molecules that's commonly present in the bile is called alkaline phosphatase. Another one is called, and we already should know this one, bilirubin. Bilirubin. And here's what's really interesting about this one. The alkaline phosphatase will be super elevated because normally, again, this is supposed to move downwards. You're not moving it downwards. This is being obstructed at this point here, just like it's being obstructed at this point here. So this will build up and leak into the bloodstream. So you test it, you'll see that elevated. But here's the other helpful one. This one's gonna be elevated. You won't see bilirubin generally elevated because it's not obstructing the flow of bile downwards here. It's obstructing it here. So because of that, you know what's one of the common manifestations that you'll see primarily in choledocholithiasis that you won't see in cholecystitis? Jaundice. You also generally won't see that massively elevated alkaline phosphatase. The other thing is that, again, if you distend all of this biliary duct tree, so you are going to get some degree of increased back pressure, let's say, within the biliary duct and then the common hepatic duct, and that will cause distension. But in this part yet, you haven't allowed enough bacteria to colonize. So there hasn't been any bacterial colonization and infection proximal to that obstruction. And that's really important to remember. So there is no infection or inflammation in the sense that there's bacteria that are causing it. It's gonna be a little distended because of the actual obstruction, but there is no infection of that biliary fluid. If I tested that fluid, it's not gonna be infected. If I test this next one's fluid, it will be infected. That's the big difference here. So you're gonna have right upper quadrant pain, jaundice, and elevated alk phos. Right upper quadrant pain, no elevated alk phos, jaundice. We come to this last one here. This is the scary one. This is the one that'll kill people. It's called ascending cholangitis, all right? The concept here is the same thing, in the sense that You know how like Cholelithiasis, you can have a stone that gets stuck in the cystic duct, it can ball valve, but you don't get an infection and all that kind of stuff like that. You get the biliary colic. That's one of the big differences between cholelithiasis and cholecystitis. One of the big differences between choledocholithiasis and ascending cholangitis because they're both stuck in the same place. They're both stuck in the common bile duct, the CBD. What's the big difference? Well, same thing. You're going to get all this back pressure. All that bile is going to circulate backwards, and you're going to get the elevation, real scary elevation, and alk phos, real significant elevation, and bilirubin, which will precipitate jaundice, right? So these are going to be definitely elevated, and you're going to stimulate the formation of jaundice here. So far, similar. Big difference is that all this bacteria that is going to be forming proximal to that obstruction are going to start colonizing, infecting the biliary fluid and the biliary tissue. Now you have infection and inflammation of the biliary tract. And the thing is that some of that infected material can start spreading into the bloodstream and cause sepsis. And so we'll talk about that a little bit in the complications. But the big kind of varying differences here is that you'll get two things. You get an increase in back pressure. And so you'll get that same thing. You'll get that distension of the common bile duct and common hepatic duct. But one of the delineating kind of points here is that you'll also have a lot of bacterial colonization proximal to that obstruction. And then because of that, you will develop infection of the biliary fluid in the biliary tract. And so I think that's one of the real important differences to delineate here is that this will trigger this, which is the same in that one, but this one is really the difference here. Okay, and we'll talk about some of the true key complication-like differences that are key between these two. But again, right upper quadrant abdominal pain, right upper quadrant abdominal pain, jaundice, jaundice, infection, no infection, both distended. This one, stuck in the cystic duct, not in the common bile duct. Right upper quadrant pain, Murphy's sign, will have infection. Cholelithiasis may ball valve between the cystic duct there, will have pain, but it's more of a colicky pain in that right upper quadrant. Now that we've defined that, let's now go into the complications of each one of these. All right, guys, so now on to the complications of biliary tract diseases. All right, so we talked a lot about the pathophys behind developing gallstones, or cholelithiasis. We talked about the pathophysiological and definitional differences between all the biliary tract diseases. And then we talked about some subtle differences, and we'll repeat those again in this part of the lecture. But what I want to talk about now is when you have a patient who comes in with right upper quadrant abdominal pain, which is oftentimes that classic finding, they may or may not have jaundice depending upon which one it is, you want to start thinking about the terrible things that can go wrong in these diseases. So first one is cholecystitis. What do we say? It's a gallstone stuck where? In the cystic duct. Now, we said that what happens is in this scenario you develop a lot of back pressure, right? We said that that's the classic finding, is that you're going to have lots of back pressure, which causes an intense amount of distension. So whenever you have this super high back pressure, what did we say is one potential finding in combination? So you have high back pressure, which is going to trigger that distension. You're also going to have we have bacteria. We'll use this kind of color here. They kind of colonize and accumulate here in this particular area. And that's going to cause, again, this increase in bacterial colonization. So you're going to have lots of back pressure and you're going to have lots of bacteria, and this is going to trigger an infection, an inflammation of this gallbladder. So it's going to be super inflamed and super angry. So super inflamed gallbladder. Now in that gall bag is all kinds of inflamed. The classic things that you will see in these patients is we already kind of defined it. Where is this kind of located, that inflamed gallbladder? It's in the right upper quadrant. So oftentimes you'll see this classic right upper quadrant pain. The other thing is if you go and you try to palpate on that area when they take a deep breath in and they stop taking that deep breath, they'll have what's called a positive Murphy sign. You can do that on exam. You know, another way that we do this a lot of the times is whenever you grab the ultrasound, which is one of the diagnostic tests of choice here, and you push it down, oh, that hurts also. So a sonographic Murphy sign. The other thing is anytime you have an inflammation, an infection, it's going to trigger a cytokine storm. And so there may potentially, it's not always guaranteed, but there could also just be, because of this intrinsic concept of inflammation, an increase in white blood cell and an increase in the risk of developing a fever. So anytime you have a fever, you have white upper quadrant abdominal pain, and you have a leukocytosis with a sonographic Murphy sign, definitely be thinking about cholecystitis. All right, get that right upper quadrant ultrasound stat. This is a classic presentation. What I would say is the scary one is this next component. So this next component here is when that back pressure is so high that if the back pressure is so high, then the intraluminal pressure starts squeezing on the gallbladder wall. And I talked about this a little bit before. Imagine here's kind of like some arteries. And these arteries are going to be supplying the gallbladder. There's also veins and some other associated stuff. But whenever you compress, because you're causing so much stretching, so there's a, let's say, a massive increase in intraluminal pressure. All right, so that pressure be high as a mustinka. So high intraluminal pressure. When that pressure is crazy high, what it does is it compresses the vessels. And whenever you cause massive compression of the arterial vessels, you're going to lead to a wall, so gallbladder wall ischemia. And that is terrifying, my friends, is when this actually starts to occur. So if there's an increase in wall ischemia, and what's the stimulus behind this? It's usually arterial compression, but it can occur with venous compression, lymphatic compression. But I'd say the big one is arterial compression. You compress those arteries, you don't get the oxygen supply to the actual gallbladder, starts to become super ischemic because of the pressure. Now, when that happens, it's a terminology that we refer to as gangrenous, because it's dying. It's kind of an ischemic and dying gall bag, so we call this cholecystitis. So this is an identifying factor here of gangrenous cholecystitis. Now, you may not be able to identify this off of any particular physical exam findings. They may have an increase in white count, they may have a fever, they may have right upper quadrant abdominal pain. Sounds exactly like regular cholecystitis. How do I identify that parts of this gall bag is becoming ischemic and then unfortunately necrotic? It's via the next set of complications that arise. So as this occurs, you start seeing these patients convert into these. And this is where you see some scary stuff. So one thing is, imagine here this gallbladder is super ischemic and this tissue starting to die, super weak, and all of a sudden, I get a perforation. That's a terrifying kind of complication, wouldn't you say? So this is definitely one potential complication of having that gangrenous cholecystitis. Is that one thing that can happen is you can definitely trigger perforation. So gallbladder perforation. Oftentimes this may seem kind of like odd, but I think when I explain it here in a second, it'll make a lot of sense. So usually what happens is these patients have so much back pressure and distension, it's so painful. When they perf, initially, they'll have a massive relief of their pain. So look for a pain relief. But then you know what will happen? This is gonna spill into their peritoneum. They're gonna develop peritonitis, sepsis, and they're gonna get sick as balls. So they're gonna get terribly ill. But look for like a temporary or transient pain relief, or if they're right upper quadrant abdominal pain, that could be a signal. This may signal you here, I'll write this down. This could signal the fact that this patient has developed a gallbladder perforation, okay? So that's one complication. The second one is you can perf, but you don't perforate into the peritoneum. So you'll get pain relief, but then again, let's actually make sure we talk about this. It'll be quickly followed by death. I'm not trying to make that funny, but it's seriously true in the sense that these patients will get terribly sick. So they will quickly follow into peritonitis. So I just want you to understand, they'll have a quick pain relief, but then they'll ensue into peritonitis. This next one is they will not they'll actually fistulize. And so what will happen is they'll create this little tract that occurs between the gallbladder and the small intestine. And this is really interesting because now some of these stones that may be here can just rock their way out into the actual small intestine. And they may work their way down the small intestine, these stones. And then what happens if this gallstone gets stuck? And you know where the most common area for them usually to get stuck is in the ileum, right at that junction. And so because they often get stuck in the ileum, they cause features of small bowel obstruction. But it's due to a gallstone being stuck in the ileum, so we call this, wait for it, you're never going to guess it, a gallstone ileus. And oftentimes what will happen is these patients will develop features that'll be significantly identifiable based upon a small bowel obstruction. So that's one of the biggest things, is that this can trigger findings of small bowel obstruction, which will be, again, cramping, abdominal pain. They'll have vomiting. They'll have difficulty being able to pass gas or pass stool. And they'll have a lot of abdominal tenderness. So these are usually classic features associated with a small bowel obstruction. But this is the big things I think that you should be able to realize. So to again quickly recap, cholecystitis, right upper quadrant abdominal pain, Murphy sign, usually due to an inflamed gallbladder. If it becomes inflamed for a long period of time and the pressure backs up and it causes it to become ischemic, gangrenous cholecystitis. May not identify any particular findings, but when it perfs, quick relief, peritonitis, we have gallbladder perforation. If it does not perf, but it fistulizes, ooh, what's that terminology? We should actually quickly write that down, because you may see this on the exam. It's called a cholecystoenteric fistula. Cholecystoenteric fistula. So in this particular type of problem here, you're having a fistula that's forming between the gallbladder and between the enteric system, in this case the small bowel. And then you'll proceed with a small bowel obstruction. Okay, we got down the complications there. What about this next monster? The next monster here is called Choledocholithiasis. We already talked a little bit about it. It's a gallstone stuck within the common bile duct. We said that the problem with here is that you'll get a lot of back pressure. And we said that that back pressure will lead to specific molecules leaking into the bloodstream that we discussed, such as an increase in alkaline phosphatase, an increase in bilirubin. They'll have that classic right upper quadrant abdominal pain that we talked about here. So these are definitely pretty easy to identify, right? Now, the one thing that we said is that choledocholithiasis doesn't have the classic features of infection. But if this patient does allow for bacteria to colonize, it can progress, and we'll talk about this. This over time can lead to this disease that we're going to talk about a little bit, which is ascending cholangitis. Okay? So I do want you to understand that it can cause bacterial infection of the biliary tree, and when that happens, we have crossed over from choledocholithiasis to ascending cholangitis, and we'll talk about that in a second. One thing, I think going into the next part here, when patients develop choledocholithiasis, the stone can get stuck in the common bile duct. But the common bile duct goes all the way down here to the pancreas. And so here you have two ducts. Here is the common bile duct, and here is the pancreatic duct, like the main pancreatic duct. And where they usually join is called this ampulla, called the ampulla of Vater, or the hepatopancreatic ampulla. Sometimes if that stone gets stuck right there where the common bile duct and the pancreatic duct fuse, the hepatopancreatic ampulla, you can get choledocholithiasis, so you get all that backflow, increased alk phos, increased bilirubin, potential for ascending cholangitis, but you know what else you can get? All of this pancreatic fluid can back up, and it can cause obstruction of the pancreatic ducts. And when you obstruct the pancreatic ducts, it'll cause inadvertent activation of the pancreatic enzymes. all these pancreatic enzymes, lipases, proteases, amylases will start digesting the pancreatic tissue undesirably. Look at this thing. It's going to get hot. It's going to get inflamed. It's going to get angry. What is that called when you inflame the pancreas? It's called pancreatitis, right? So another potential complication of this kind of obstruction here, and I'd say it's by far one of the most common causes of pancreatitis, is going to be a gallstone there. So watch out for development of pancreatitis in the setting of choledocholithiasis. Did I spell it right? Pancreatitis. Now, oftentimes pancreatitis presents with that classic epigastric abdominal pain, elevation in lipase. That's usually 3 times the upper limit of normal. We'll talk about that more in that video. But realize that gallstones, particularly at that level, can definitely be a very common cause, along with alcohol, as the most common causes of pancreatitis. Okay, beautiful. With that being said, we've talked about cholecystitis. We've talked about how that one causes the classic findings: gangrenous cholecystitis, gallbladder perforation, and gallstone ileus. We talked about this one with pancreatitis and the risk of developing ascending cholangitis. Let's now talk about ascending cholangitis. In ascending cholangitis, same thing, stone stuck within the common bile duct. The differences between choledocholithiasis and ascending cholangitis, though, is that this one was just biliary fluid that's not infected. And this one, you see these like kind of maroon dots here? These are going to be bacteria. Here, let's actually recognize that this is going to be a biliary fluid, so a bacteria-rich bile. We're going to call this infected bile. Sounds terrible, right? But it's because this obstruction is impeding the flow of normal bacteria-containing bile. So what happens is this biliary fluid, which is rich in this infected material, will move backwards and it'll get into the bloodstream, right? So you're going to have this bacteria. It's going to cause inflammation, infection of all of this biliary duct. So you're going to get some angry, inflamed, let's actually write that down. You're going to get some inflamed ducts. Some inflamed common bile duct and hepatic ducts, and that's going to cause that classic right upper quadrant abdominal pain, right? Classic. What's associated with this was when the bacteria get into the bloodstream. And that's what's terrible. Because sometimes when the bacteria get into the bloodstream, one of the common things that usually may actually arise initially. So now we have what's called bacteremia, bacteria within the bloodstream. One of the big things is that this may activate your immune system. And so what will happen is, and poor neutrophils are going to pop off, right? So you're going to develop an increase in the white blood cell count. That's one thing, right? So this is going to pop off them white blood cells. Second thing is it's going to stimulate cytokines, which will then cause your hypothalamus to crank up your body temperature. And so you may have a fever, which is, again, greater than 38 degrees Celsius or greater than 100.4 degrees Fahrenheit. So you may have a high fever and white blood cell count. You may also have right upper quadrant abdominal pain. But there's one more thing. This bile is rich in bacteria, but I've already said what it's also rich in. It's rich in bilirubin. And so it's also going to be a ton of bilirubin and what we talked about before, alkaline phosphatase, but this is the pertinent one here. It's going to be in high amounts. When this is in high amounts, what do you think it does? Deposits into the skin, deposits into the sclera, and causes jaundice. Okay. With that being said, when a patient has right upper quadrant abdominal pain, when they have jaundice, and when they have features of infection such as elevated white blood cell count, but more particularly a fever, these are very suggestive of ascending cholangitis. You know what they call this? We say that this is referred to as Charcot's triad. So Charcot's triad is right upper quadrant abdominal pain, jaundice, and a fever. And sometimes if you get a white blood cell count, you get a CBC, you may develop a elevated white blood cell count. Okay, what if I took this a little bit further and I had a patient who now had even worsening bacteremia? So going off of that, let's say that we just focus on the bacteria. This biliary fluid is super scary, super rich in bacteria. And now this bacteremia is off the chain. And when it gets off the chain, it starts wreaking havoc on our circulatory system. So now these patients get terrible bacteremia. And what happens is this will then trigger a massive, so now our white blood cells are going to start trying to fight off this bacteria. And there's going to be a problem here where not only is there going to be lots of white blood cells, there's going to be tons and tons of cytokines. So you're going to have lots of white blood cells, lots of cytokines, so many. I'm not going to go crazy, but like interleukin 1 and interleukin 6 and tumor necrotic factor, all these dang things. These things are going to be in massive amounts. This is going to be in massive amounts. The whole problem is they're trying to come and ward off this bacteria. But unfortunately, all of these cytokines wreak havoc on our circulatory system. And what they do is they make your circulatory system super dilated and super leaky. So here's a blood vessel. This blood vessel is super leaky. And now fluid will leak out of these capillaries. And now what happens is I lose my systemic vascular resistance and I drop my blood volume. And so now what happens is these patients usually develop hypotension. They develop low blood pressure. And that low blood pressure will then lead to the patient having shock. So we call this septic shock. When it's due to bacteria, this is a very specific type. So we call this septic shock, if you will. Here, let's actually write that down. So this is actually specifically what type of shock is a response to the low blood pressure. This is septic shock. So they'll have terribly low blood pressure. They won't perfuse organs. And as a result of that, one of the most sensitive organs tends to be the brain. And because of that, they'll have hypoperfusion of the brain and they'll develop an altered mental status. So now, hypoperfusion of the brain due to low blood pressure stimulates an altered mental status. It's interesting. So now if they have hypotension, shock, and altered mental status, you know what we call that? We call that Raynaud's pentad. All these like dang weird things. But Raynaud's pentad. All that is a combination of Charcot's triad. So it's Charcot's triad plus these two factors here. Low blood pressure or shock and altered mental status. So now, if a patient has ascending cholangitis, this looks like it could be the worst possible scenario, correct? Absolutely. This is the one that'll kill you and cause a patient to become septic. I think with that being said, we now have a good idea of the biliary tract diseases, their complications, their pathophys. Now let's hit the diagnostics. So now you kind of get to the point where you're like, okay, I have a patient, they're coming in, they have right upper quadrant abdominal pain, maybe or maybe not, they have jaundice. I got to start thinking, okay, how can I really get to these diagnostic approaches here? Well, the first thing is get a CBC. I find that this helps because it helps you to see is there leukocytosis that's associated with a fever. If they have a very high white count, then I definitely think that there's an infection of the biliary tree. And there's only two types, cholecystitis or ascending cholangitis. So that helps me out a little bit. Then let's go to the next thing. Let's get some LFTs and take a look at the LFTs. If there's a high bilirubin and there's a high alkaline phosphatase and maybe a mild increase in the AST and the ALT, here's the thing that tells me that I have to have a stone that's somewhere in the common bile duct. So if I have a high white cell count and I have a high alkaline phosphatase and bilirubin levels, I know that it has to be ascending cholangitis. But if I don't have like a high white blood cell count, I don't have a really high fever, but I do have an increased alk phos and an increased bilirubin with right upper quadrant pain, it's probably Choledocholithiasis. If I have a high white blood cell count and I have really no increase in bilirubin or alkaline phosphatase, then I should suggest that it's cholecystitis, especially if I have a fever and right upper quadrant abdominal pain. So let's go to the next step, which is let's get a right upper quadrant ultrasound, because this will give me a lot more information. If I do this and I look here and I say, oh, here, there's a bunch of gallstones. All they have is right upper quadrant abdominal pain. They have no issues with their LFTs, no white cell count. Well, if that's the case, it's probably just cholelithiasis. Maybe they have some biliary colic that's going on, and it's because of the fat occurring meals. All right, that's not a true cholecystitis, ascending cholangitis, or choledocholithiasis. Cool. What if I look at the right upper quadrant ultrasound, though, and I say, oh, shoot, here's the biliary duct, the common bile duct, and I see a stone here, and the actual biliary duct's pretty dilated. Okay, well then I know then if they're presenting with right upper quadrant abdominal pain, increased alk phos, increased bilirubin, no significant white cell count or fever, it's probably choledocholithiasis. But if they present with a stone, dilated bile duct, white cell count, high alk phos, high bilirubin, then that's probably ascending cholangitis. The next thing is if I see, oh man, there's definitely a gallstone that's present in the gallbladder. They have a sonographic Murphy sign. So when I use the ultrasound, I push into that right upper quadrant, it causes an intense pain. They aren't able to breathe. I also see that the gallbladder wall is really thick, it's distended, and it even has some fluid around this area here. That's super diagnostic of cholecystitis, especially if they have a fever, again, right upper quadrant abdominal pain, and usually an increase in white cell count, usually no changes in their alkaline phosphatase or their bilirubin, and that's going to help me out. Now, let's say that I get a patient who has right upper quadrant ultrasound, right upper quadrant pain. I give them a sonographic Murphy sign. They have a fever. They have a leukocytosis, but their right upper quadrant ultrasound is inconclusive. It's not really super diagnostic. It doesn't give me these findings. Well, then the next test is to do something called a HIDA scan. You give them a radioactive tracer, and what happens is it fills the biliary tree. If there's an obstruction in the gallbladder, then it won't fill the gallbladder. And so what we're looking for is we're looking for areas where the tracer is not emptying into the gallbladder. And if we don't see the tracer in the gallbladder, we know that there's an obstruction of the gallbladder. And that would tell me, oh, they definitely have a stone there. It's likely cholecystitis. So again, no tracer filling the gallbladder, it's cholecystitis. So at this point, you should have an idea now of how to go about diagnosing a patient who has a biliary tract disorder: cholelithiasis, cholecystitis, choledocholithiasis, and ascending cholangitis. Again, look at their clinical features, look for a white count, look at the LFTs. Again, only alk phos, bilirubin, and common bile duct stones, only leukocytosis and infections, cholecystitis and ascending cholangitis. Right upper quadrant ultrasound, if it shows a stone in the gallbladder, but they don't have any other features of leukocytosis or cholestasis, it's cholelithiasis. If they have white cell count, no cholestasis on their LFTs, but they do have a stone in their gallbladder, thickening, all of the findings there, it's cholecystitis. And if not, get a HIDA scan to confirm. If they have no white count and they have, again, a cholestasis injury, and then again, you look at the right upper quadrant ultrasound and you see a stone there with ductal dilation, it's choledocholithiasis. If I see a white count, cholestasis, and I see a stone with ductal dilation, then I know that it's ascending cholangitis. All right, now we move on to the treatment. How do we treat all of these? Well, cholelithiasis, oftentimes we may do nothing. But if you're really trying to reduce the formation of gallstones, you can use a drug called ursodeoxycholic acid. This is preferred for patients who don't want to undergo any surgical or invasive therapy. Ursodeoxycholic acid has been shown to reduce the formation of gallstones. So it can reduce the rate or recurrence of gallstone kind of formation and reduce the events of biliary colic, cholecystitis, choledocholithiasis, etc. If you completely want to go the invasive route and prevent a patient from ever obstructing their biliary tree because of them having cholelithiasis, then you can just go ahead and ask the patient if they want to get a cholecystectomy, and it's more of an elective process. And they can do it laparoscopically, where they go in with all of these particular scopes and cut out the gallbladder, or they can open the patient up and then cut out that gallbladder. But either way, that'll prevent them from developing things like cholecystitis, choledocholithiasis, and ascending cholangitis. What if they have cholecystitis? Well, it's important you got to get rid of the infected gallbladder. So again, you're either going to do this laparoscopically or open, but it's important to emergently get them to the OR and cut out the infected gallbladder. And in the meantime, give them some antibiotics to start cleansing that actual infection. So usually this is things like ciprofloxacin and metronidazole until you get the patient to cut that gallbladder out. You keep them on it for a little while, and then eventually they won't need the antibiotics any further. However, some patients may be super critically ill and not be able to survive a cholecystectomy. So in that particular scenario, we won't take them to the OR. We'll put them on antibiotics, ciprofloxacin, metronidazole, but then we'll come to the bedside, and what we'll do is we just got to keep getting rid of the infected biliary material so it doesn't cause gangrenous cholecystitis. They don't have a perforation or a gallstone ileus. So what we'll do is we'll take and we'll provide an alternative path, and we'll take this tube at the bedside, run it right through into the gallbladder, and provide an alternative route for that area to decompress. So it reduces pain and gets rid of the infected material. This is called a percutaneous cholecystostomy. We only do this in patients who are not good candidates for a emergent laparoscopic or open cholecystectomy. All right. Next one's Choledocholithiasis. It's really just important to remember if they have findings of ascending cholangitis, or if they have gallstone pancreatitis, and there's lots of pain that they're not just improving with medical management, you need to remove that stone. And the best way to do that is what's called an ERCP, which is an endoscopic retrograde cholangiopancreatography. You take a scope, it goes down through the duodenum, you run it and kind of cut through this little sphincter of Oddi, and you run up through the actual common bile duct, and you suck out all of that stone. And that's where you're going to remove these stones. But again, it's important to make sure that you do this in the indication of where it's necessary, such as refractory pain, they have gallstone pancreatitis, or they're developing ascending cholangitis. Then you'll remove this stone. With that being said, if a patient does have ascending cholangitis, it is of utmost importance to get that stone out of there. So you're going to put them on antibiotics to start to try to clear some of that infected biliary fluid, but then get in there and get that stone out so that you prevent them from developing recurrent infections, so that you can liberate normal flow of bile and stop that bacterial stasis and colonization. All right. The next thing is, what if I have a patient just like a cholecystitis patient who's super critically ill? Well, same thing. Maybe they're not a good candidate for me to go to the endovascular, the suite for endoscopic study. In other words, I cannot get them to the endoscopy suite to do an ERCP. They're just not stable enough, and they probably wouldn't do well with that surgery. Well, I'll continue the antibiotics to kind of clear up that infected biliary fluid, but I'll do a percutaneous cholecystostomy, again, to keep removing infected fluid from the gallbladder, from the biliary tree, so that it doesn't cause further distension, so that'll remove pain, and it also will clear some of the infected material so they don't become septic and developing that Raynaud's pentad. And that's how we would go about treating this. All right, my friends, that was a lot to talk about with biliary tract diseases. I hope it made sense. I hope that you guys did enjoy it, and as always, until next time.